Greetings and welcome to the International Pediatric Simulation Society podcast. This show is for people passionate about pediatric simulation-based education, training, and research. Podcast hosts are members of IPSS, a global community of multidisciplinary healthcare professionals from over 30 countries, all dedicated to improving the care of infants and children worldwide. Each week, one of our sub-hosts, Christine Bailey, Elaine Ng, Aaron Karn-Bennett, and myself, Samreen Vora, will introduce you to a new guest and bring you into a conversation with simulationists and healthcare professionals from across the world. Come along. Dr. Samreen Vora here, and on this episode, I'm speaking with Dr. Lauren Rissman, who is a pediatric critical care physician and physician educator specializing in pediatric palliative care, communication science, and disparities in critical illness. She completed her pediatric residency and chief residency at Children's Hospital Los Angeles, followed by a fellowship training in pediatric critical care medicine at Ann and Robert H. Lurie Children's Hospital of Chicago. Her scholarly work focuses on improving how clinicians communicate with families during high-stakes situations, including serious illness, prognostic uncertainty, and end-of-life care. She has contributed to the literature on pediatric palliative care integration in the ICU, communication training for trainees, and disparities affecting children with medical complexity. Dr. Rissman's current research explores innovative, scalable approaches to communication education, including simulation and artificial intelligence-based tools, with the goal of translating experiential learning into measurable competence. Her work sits at the intersection of critical care, medical education, and health equity, with an emphasis on preparing clinicians to deliver high-quality, family-centered care in the most challenging moments. Dr. Rissman, we just heard your bio, and I am excited to have you on our episode today.
Thank you for having me. It's an honor.
Well, and we met at IPSSW, and it was your first time at the IPSSW conference this year. How was that for you?
I mean, first of all, traveling to Rome was incredible. So that aside, it was really cool to see what people are working on, like literally around the world. It was amazing to have everybody together.
Yeah. I mean, we don't put aside the Rome piece. We are very thoughtful. I think the board, I say we, I was on the board and am not at this time. And I know that they're very thoughtful about where the conference happens, and also very thoughtful about that piece of it is to very much have it be an international dialogue and exchange of ideas. And it sounds like that is what it was for you. And so that's kind of awesome to hear. And I'm also glad you enjoyed Rome. It was my first time in Rome as well. And it was pretty incredible.
It's amazing. It's amazing between the mix of ancient history and all these new things happening. And I guess sort of parallels IPSS as well.
Yeah. Oh, I love that. I love that connection. I'm sure a lot of our folks listening will kind of like that parallel as well. That's exactly right. So as we heard in your bio, you are doing a number of really cool things, and you have a background in critical care medicine and palliative care. I want to jump into this conversation with all of that expertise you're bringing and ask you what led you to this space that you're in this work, and then eventually maybe move to talking about what led you to IPSSW and to simulation.
Definitely. So going back to fellowships, I did critical care fellowship at Lurie in Chicago. And I did a study with Kelly Michelson that was published in PCCM about what patients think we say to them and what physicians think we're saying. And we looked at the concordance between the two. And then we asked parents if they want to be told more things about what life might look like after discharge. As you can imagine, the concordance was non-existent, and parents generally wanted to know more, even if they had shared that the physicians did tell them things about what life might look like. They still wanted to know more.
I think it's interesting that you say, as you can imagine. And I think we are both in the same kind of niche space of communication. And I've heard a little bit about some of your experiences, and I think we've also had similar experiences in our personal lives. And so for you and I think it's easy to say, yeah, as you can imagine, these things didn't match up. What the patient thought, heard, and what the physicians thought they said, there was not great concordance. But I think there's a lot of people out there that would be surprised by that. And I work in the emergency room, you work in a critical care space. We all wear different hats too. So when I'm wearing my physician hat and I have a nurse come up to me and say, hey, that patient wants to talk to you. And I'm like, well, I already spoke to them. Like I just explained all of that. Or they say, hey, they have this question. I'm like, I literally just answered that question. So I think it is obvious to us now, but I don't know that there's a lot of people that realize how disparate that is.
Yeah. And I think too, from a personal standpoint, I became a mom, but not just a mom. I became a NICU mom while also myself being sick and living in the ICU. And so I feel like being on the other side of medicine, you see a lot of gaps in communication that really shouldn't exist.
Yeah, I 100% agree. And when you're on the other side, my father, when he was diagnosed with a terminal diagnosis and we were going through the process and it was over 1 year, I just remember very, very vividly remember, right? I might not remember all my patients and the patients I've had this conversation with, but I do remember every single conversation I had when it was with my father and I was on the other side. And I think that is a reminder to me when I'm wearing my other hat as a physician, how it felt. And I remember conversations where people would say things to me that were just like, whew, what? I cannot believe that was said to me. And you hold on to that.
Yeah, it's humbling and you can't not practice medicine differently after that experience.
Exactly. And so that's why I do simulation. And it sounds like you had a number of experiences that coincided that kind of led you to this path of focusing on the communication and then eventually tying that to simulation. I wonder if you could share a little bit more about that.
Yes. So both my first daughter and I survived. And then I had a chance to do palliative care fellowship after that, really because I wanted to be considered an expert in the field. And so I wanted to be able to say hard things compassionately and directly. And then I felt like it was my duty to pass that on to the next generation. Simulation to me felt like the next best step in this.
Yeah. To make it tangible, take all of those experiences you had. You said to me, you became a NICU parent, a critical care fellow, and an ICU survivor all at once. And all of those lessons, you're like, what do I do? Looking at that very first study you did, which sounds like you did that study before you had these experiences. So you were already interested in this space.
Yes.
And so taking all of that and saying, hey, these perceptions are not aligned. And you said, I want to minimize that discordance. You want my work to be impactful where I can minimize this discordance between patients and families and physicians.
Exactly.
And work with that next generation. Yeah. And you also mentioned there isn't standardization in this. So as you come to simulation and you say, hey, how do we teach these skills better? How do we teach them consistently? I think is the big question, right? There's pockets and people are doing this. How do we do this more consistently? And I know you had some work you've done recently. If you could share about that.
Yeah, absolutely. So not every program is created equal. And so I had the opportunity to be a part of the Society of Critical Care Medicine's End of Life Guidelines Committee. And so together we created guidelines for NICU, PICU, and the PCICU population at end of life care. And then I also simultaneously was working with a smaller group of people on creating EPAs. So those are professional activities for trainees. And essentially, the ABP, so American Board of Pediatrics, says to critical care fellows by the end of fellowship, you should be expected to do end-of-life care. But then they don't specify what that looks like, what that means, and how you gain competency. Mm-hmm. And so we created these EPAs, and then we started to look at, okay, well, what's published in the literature? And so a smaller group from the EPA group looked at the literature and did a review to look at that actually just came out recently, but looked at the literature and said, okay, well, of X studies, there are really only 6 studies that have clear objectives, and none of the objectives are the same. none of the measures are the same and none of the outcomes are the same.
Wow. And I think it says your data was 105 articles, and there were 6 articles that actually addressed kind of those pieces that you're talking about.
Yes, exactly.
That's a big deal, right? Like there's work being done, but it's not streamlined, it's not clear, and it's not standardized. And I think that that's really important. And how do we train folks to do this better? And so simulation is the answer to everything. Maybe not everything, but it is the answer here.
It's a step closer, that's for sure.
Yeah.
And the alternative is just doing it with our patients and then either never getting feedback from somebody who has more experience and just doing it, or practicing and pausing and rephrasing. And the patients are the ones that suffer.
Yeah. As you and I, things we remember from our experiences being on the other side of the bed, or in the bed, I suppose, is challenging. So tell me more about the work you're starting to do in simulation.
Great question. So right now we know that for communication training, using standardized patients is pretty costly from a resource standpoint, from a financial standpoint, from a time standpoint. And so we wanted to make it so that things are more accessible. And so we're working to harness AI and create cases with objective measures and outcomes and feedback that you can trend over time. So you can look at competency as objective numbers as opposed to a feeling or a perception.
Which is important, because I think in this space, when we hear people talk about communication, we often hear it talked about as a non-technical skill or a soft skill, and almost as if, hey, are there measures, or is there, how can you get concrete, because it's subjective. And honestly, it isn't necessarily. There are concrete competencies, and there are frameworks, and there are very specific things that we know from the literature that are evidence-based that make us better at communicating.
Yeah, that's true.
So it sounds like you're taking that and embedding that, right? And providing a platform where people can practice and get feedback.
Exactly. So the feedback takes the quotations, says, okay, you said this really beautifully, and then also gives you some deltas. So I see that you said this. In order to achieve, a higher score, you might consider explaining this thought process a little bit more. Or instead of this, you might consider saying, explaining what a breathing tube is as opposed to just saying a breathing tube.
Yeah. We have a lot of folks, right, that use medical terminology and don't even realize that that's what they're doing. That's awesome. And this allows for scalability, or even more psychologically safe practice without having others that are watching, being able to practice your own space, maybe practice more often. It sounds like that's what's been on your mind.
Exactly. It feels safe and accessible. And, your program directors or whoever else can watch your tracking from afar.
Say more about that.
So there's a dashboard associated with it. A program director or mentor, whomever is assigned to support trainees in communication education, are able to actually watch to see if trainees are meeting competency. And again, we have objective metrics that we're measuring. And so you might be expected to practice with a simulation a handful of times, and the goal would be to achieve closer to a perfect score each time.
Interesting. Yeah. I wonder if that's a way, as you think about, you can track how well someone is doing across time. I also am a firm believer that I don't think AI can replace these human encounters, and I don't think we want it to. So we still want that SP-based education to continue. We still want real humans to be providing feedback to our trainees, but at the right time. And so it sounds like the potential to scaffold, it would be a good way to use it.
Exactly. So this is absolutely not replacing human interaction. There is a hospital system we're working with right now whose hope is to have trainees use this in preparation for their OSCEs. So basically saying you're not allowed to sit for your OSCE until you achieve competency using this tool.
To provide more scaffolding and more training and more practice in a space, which is what simulation's all about, right? To all the practice that you can. And so this could be a tool that you can scale that with. I'm curious, what are the challenges you've run into? Are there things that you're worried about, right?
I guess relating back to IPSSW, Todd Chang did a really cool VR presentation, and it was helpful to watch and helpful to talk in small groups about how you would debrief this with a trainee. I also can't help but think still feels very different than what reality actually looks like. And so it's a step in the right direction, but it doesn't fix things entirely. The same thing goes along with AI, where this is not a perfect solution by any means. And it's going to continue to be tailored and get better and maybe get worse in some ways, but it's a step in a direction.
Yeah, I think you're 100% right. We're all trying to figure out what are the best uses, how can it scaffold the learning for our trainees and even our practicing professionals. I'm curious if you've had any experience beyond the trainee level, because I think that's another space where after you're out of training and someone's monitoring all your competencies and all the things, you don't really get to, one, get feedback on how you're doing, and two, see how your colleagues are doing. And, a lot has evolved over time, particularly in this space. I imagine there's a number of folks out there that maybe didn't have any training in this space, when they were training.
So that's a really interesting part of this. We did a national needs assessment, and this publication is not yet out. So we asked critical care fellows, so current critical care trainees, and then we asked current critical care faculty how competent, confident, comfortable they feel having these hard conversations. And the group that has felt most confident are those out of training for more than 10 years, and that same group has also had the least amount of training. It's fascinating to me that there's a lack of perception of training and also confidence and perceived confidence, so completely opposite. What we know currently from the AI study that we're running is that there's essentially no association between perceived competence and the objective competence we're getting as output from the AI.
Interesting. And we know that from the general literature as well. Confidence does not equal competence. In fact, it's sometimes the opposite. I'm curious, that last piece you shared, was that in practicing professionals?
Yes. Yeah, practicing professionals.
Yeah, and that's fascinating, right? 10 years out, it's possible that maybe they are better because they've got quite a number of years of experience under their belts, but also it's possible that they were never trained on doing it well and they're not doing it well for 10 years. And they're the ones that maybe you and I intersected with when we were on the other side. Not to call people out, but truly, right? This is skills that have developed and they weren't given the tools. And honestly, the goal would be, it's not about shame or guilt or any of that, right? It's about giving the tools to the folks that are working in this very difficult space so that they can do better for their patients and so they can minimize their own moral distress about how they're doing in that space. I actually remember we did a communication training using simulation in one of my past roles, and it was for all levels. They were all practicing professionals, and it was interdisciplinary. So there were physicians, advanced practice providers, nurses, chaplains, social workers. And the person that we got the most raving reviews of how incredibly helpful it was, this was not AI, it was SP-based simulation, but to the point of the skills you're training, was the most senior. They were actually the head of that department. They were the head of the neonatal department, and they had this chance in a small group to do a simulation with an SP and get feedback, and were open to that feedback. And then afterwards had the most raving review of our simulation was this person who had been out the longest. And they were like, wow, I've never received feedback. And that was the most helpful thing, to receive the feedback, to be able to practice. And I was really surprised. I was kind of nervous and we were really surprised. And so to your point, this might provide that kind of a platform, a psychologically safe space that's scalable to the degree where it can be used by folks that are across the spectrum of experience.
Exactly. I love that story. Yes. That is definitely the hope. And to get it into the hands of people who are in the community. So we have the luxury of having simulation centers in our facility, but what about the people that are in the community or, deep abroad villages, right? So really, I'm really hoping to make this scalable and accessible.
Yeah. Accessibility, I think, is a huge piece of that, right? When we talk about simulation and SPs and simulation design and all the things, how do you make it more accessible is key. And I think for this community, it's a very international community. There's the potential for flexibility as well. Communication standards are different in different settings, and you could pretty rapidly build something that, whether it's different languages or different rubrics or different just standards of expectations variations of how things are said. The potential is really great to be able to scale this even at that level.
Thank you. Yeah, I'm excited and overwhelmed and excited.
Yeah, and there's a lot of work ahead. I think this tool and this work that you're working on and being able to see you presented at IPSSW. And is there anything else that we haven't chatted about that you want to share?
I don't know. I'm looking forward to the next IPSSW. I think it's a really cool way to connect with other people who are interested and passionate about the same thing. So there's that.
I love that. That's perfectly circular. It's the beginning of our conversation. And the next IPSSW will be in Dublin in May of 2027. And you and I will meet again there. So a lot of work to be done. And it'll be exciting to see where things are at next year.
We'll be there.
All right. Excellent. Well, thank you so much for joining us on this episode.
Good. Thank you so much for having me.
Thank you for listening to this episode of the IPSS Podcast. A special thanks to our behind-the-scenes producer, the talented Danish Kumar, and to the Starship Foundation for providing the equipment that makes this podcast possible. Join us next time.